Hello, and welcome to Breaking New Ground in Hormone Testing. Introducing the Hormone Zoomer. My name is Adair Anderson. I am Vibrant's product marketing educator and so excited to tell you about this new test. But before we get started, a couple of housekeeping items. All attendees are in listen only mode, so if you have questions during the presentation, please submit them as a comment. There will be time at the end for Q&A. Here's our agenda. First, I'll provide an overview of hormonal imbalances and we'll compare common hormone testing options. Then, I'll introduce Vibrance Hormone Zoomer. We'll do a report walkthrough reviewing all that's included with this test, highlighting the gold standard methodology. Then, we'll apply what we've learned in a case study and end with a discussion about synergistic tests. Lastly, I'll extend a special offer, so be sure to stick around until the end. Hormones control many different bodily processes, including metabolism, homeostasis of blood pressure, blood sugar regulation, fluid and electrolyte balance, and body temperature. Also, growth and development, sexual function, reproduction, sleep wake cycle, and mood. When hormones are out of balance, this can manifest in symptoms like fatigue, weight gain, poor stamina or poor muscle tone, osteoporosis, hair loss, hot flashes or night sweats, insomnia, low libido or infertility, menstrual cycle changes such as lack of periods, infrequent periods, heavy periods, or painful periods, and also emotional symptoms like anxiety, depression, or mood swings, all of which are common in both perimenopausal and menopausal women as well as andropausal men. There's a tendency to think that hormone testing is just for the older folks who are maybe needing hormone replacement therapy, who are going through the change. However, hormone Zoomer is valuable for pretty much anyone. Certainly, when someone is about to go through menopause or is going through menopause, you might do the test to figure out what's going on, how to adjust it. But it's also a powerful tool for prevention, helping identify whether hormones are being metabolized in healthy or unhealthy way, and also to establish a personal baseline. I mean, I wish I'd had access to this kind of testing in my 20s and 30s. I'd love to be able to compare it now to my 41-year-old self to see what's changed. While men don't cycle like women, thus are less complicated hormonally, they can still suffer from things like low testosterone, low libido, erectile dysfunction, fatigue, anxiety, or depression related to hormone dysregulation. And also for men, increased body fat and loss of lean muscle mass is a common reason to test. In other words, this test is useful for all ages and all genders. So, what types of testing do healthcare providers use to measure and monitor hormone levels? Well, it's primarily a decision between serum, saliva, and urine. Here are the strengths and limitations of each. Serum hormone testing is the current standard of care for monitoring oral hormone replacement therapy, pellets, or patches. The strength of serum is that you can test for thyroid hormones, sex hormone binding globulin, and sex steroids all in one blood draw. The downside is that, well, it's a one-time collection, so you only get that one data point. In contrast, saliva and urine are generally collected at 4 points throughout the day, so it provides that diurnal rhythm. The biggest strength of saliva testing is that saliva measures free bioavailable hormones rather than total bound hormone. Also, it's best for monitoring topical HRT like creams and gels, since saliva is more representative of tissue levels of topical hormones in serum or urine. And additionally, saliva is well researched for assessing adrenal and HPA function. The third hormone testing option is urine. A key strength of urine testing is that it includes hormone metabolites, which reflect metabolism and clearance of hormones, including liver detoxification pathways. Most importantly, urine hormones can accurately reflect baseline hormone levels in most patients. For the full list of strengths and limitations, please check out the serum, saliva, or urine handout my colleague Christopher just shared in the comments. In summary, there is no one perfect test. All testing comes with strengths and limitations. But what if there was a new testing option that provided even deeper hormonal insights? Good news, there is. I'm excited to announce the new hormone testing option today. Please allow me to introduce you to Vibrance Hormone Zoomer. Vibrance Hormone Zoomer combines evaluation of adrenal and sex hormones along with their metabolites, including diurnal cortisone, cortisol, and melatonin. along with endocrine disruptors, bone health markers, and an oxidative stress marker, all of which is going to help you identify the cause of these hormone related conditions. The Hormone Zoomer will include all the markers listed on this page. Starting with the table on the right, the Hormone Zoomer includes adrenal hormones and metabolites, hormone ratios, the diurnal 4-point cortisol, cortisone, melatonin, and creatinine, sex hormones, estrogen, progesterone, and testosterone, and their metabolites. And then looking at the table on the left, the Hormone Zoomer also includes 13 endocrine disrupting chemicals, two bone health markers, and the oxidative stress marker 8-OHDG. Vibrance Hormone Zoomer test is an easy at-home urine test. Patients simply collect 4 urine tubes. The first morning sample collected upon waking, ideally before 9 a.m. A second morning sample collected 2 hours after waking. An evening sample collected before dinner, typically around 5 p.m. And a night sample collected before bed, typically around 10 p.m. As for collection date, men and non-menstruating women may collect any day of the month. However, there are recommendations for cycling women. Menstruating women with regular cycles should collect during the progesterone peak of the luteal phase. This corresponds with days 19, 20, or 21 of a 28-day cycle, or 7 days after ovulation if tracking. For longer cycles, simply add the number of days beyond 28 days. For example, collect on days 21 through 23 for a 30-day cycle, or collect on days 17 through 19 for a 26-day cycle. For irregular cycles, collect 5 to 7 days before expected onset of menses. And for postmenopausal women on hormone therapy, collect midway between doses. Important note, for optimal and clinically relevant results, patients should maintain routine diet, medications, and supplements unless specifically instructed otherwise by their healthcare provider. This approach ensures accurate assessment based on their usual physiological state. Dietary restrictions include avoiding foods high in phytoestrogens, such as soy products, flax seeds, and licorice, as well as dopamine influences like bananas, avocados, and fava beans for 48 hours prior to collection. It's also good to limit consumption of alcohol and caffeine. Supplement restrictions include avoiding tyrosine, quercetin, and mucuna for 48 hours prior to sample collection. And as for hydration, patients should avoid fluids 2 hours before each sample collection to prevent sample dilution from overhydration. Since the hormone zoomer is used to monitor HRT therapy, there are also hormone usage recommendations. Patients should continue hormone-related supplements unless instructed by their provider. Hormone creams and gels can be used as usual. For those using patches, pellets, or injection-based HRT, collections can be done midway of dosage. And if patients are instructed to stop HRT by the provider, we recommend they wait 72 hours prior to collecting that sample. Specifically, oral DHEA, oral estrogen, oral progesterone, and oral pregnenolone could impact the results, so are best to avoid 24 to 72 hours prior to collection. But of course, ultimately, it's up to the ordering provider to decide what the patient should do. As for methodology, Vibrant uses mass spectrometry to measure analytes on the hormone zoomer, and this is because mass spec is the gold standard for quantifying small molecules. Specifically, Vibrant uses gas chromatography tandem mass spectrometry, so GCMSMS, for quantitative detection of estrogens, progesterones, androgens, and metabolites, and liquid chromatography tandem mass spectrometry, so LCMS-MS, for quantitative detection of cortisol, cortisone and metabolites, melatonin, endocrine disruptors, bone health markers, oxidative stress, and also urine creatinine. So why urine creatinine? Well, this is because urine can have varied concentrations. Sometimes it's a pale yellow, sometimes it's a dark orange. Good news, urine creatinine is relatively constant, so Vibrant normalizes all markers to urine creatinine to account for urine dilution variations. All right, now that we've covered the markers methodology and collection instructions, let's do a walkthrough of the Hormone Zoomer report. And to keep it interesting, I'm going to weave in some clinical pearls as we discuss each section of the report. Before we dive in, though, I want to highlight that you get to choose how much information to include in the report you download for yourself and the report you share with your patient. You have 3 options: summary, interpretation, and all markers. I'll be going over the report that includes all 3 options combined, as it is the most comprehensive. Let's start with a quick overview. The Hormone Zoomer sample report includes a cover page, an introduction, then the questionnaire data, a summary with interpretive comments, graphs, and flowchart, and then lists all the markers. The first page of the report includes the results interpretation key and lists the sample type. Note first morning, second morning, evening, and night urine. The introduction page includes the methodology and interpretation of the report, and I highly recommend reading this page. To ensure accurate results, the Hormone Zoomer requires patients complete a hormone testing questionnaire. For female patients, it gathers key information on menstrual cycles, bone health, toxin exposure, symptoms, medical history, and treatment factors. The questionnaire data is included in the final report to support personalized interpretation. And note here that female reproductive stage, i.e., pre versus postmenopausal, is mandatory as it determines the correct reference ranges on the report. Male patients get a different questionnaire than the females. For males, it asks about bladder and prostate symptoms, for example. After the questionnaire comes the summary. The summary begins with the diurnal hormone flow chart and graphs. The upper left shows the brain signals that drive DHEA and cortisol production. And the page also includes graphs of your patient's diurnal melatonin, cortisol, and cortisone levels. The green dots are results within the reference range, and the red dots are results that fall above or below the reference range. Ideally, you want your patient's values to match the pattern of the light green shaded area. Your diurnal cortisol curve is primarily controlled by your circadian rhythm. The sign of a healthy circadian rhythm is having higher cortisol in the morning with a peak after waking, and then lower evening and night cortisol so you can fall asleep. However, stress can impact your cortisol curve. In general, anytime levels fall above the line, it indicates an overactive HPA response. Anytime levels fall below the line, it indicates an inadequate HPA response. Hans Selye is an endocrinologist known for his work on stress and identifying the three stages of adrenal dysregulation. Stage 1 is normal adaptation. Your cortisol increases with stress, but is able to return to normal. Just like Robert Sapolsky explains in his book, Why Zebras Don't Get Ulcers, zebras run like heck when a lion is chasing them, but as soon as the lion kills one of their friends, they know the danger is over, so the zebras can quickly go back to just eating grass. And this is what we want stress response to be like, right? Beginning, middle, quick to end. In stage 2, also called the resistance or adaptation phase, this is when cortisol increases and either stays elevated or becomes elevated at inappropriate times of the day. For stage 3, this is what happens when the adrenal glands run at full tilt for too long. The exhaustion phase is where cortisol is low and patients feel depressed and exhausted. So let's go over a couple of case samples now to emphasize these points. Example 1 has trouble falling asleep and difficulty staying asleep. This is because their cortisol spikes at night when they lay in bed. Maybe they're replaying the events of the day or planning for tomorrow. Instead of acute stress and a quick return to normal, this pattern reflects stage 2 adrenal resistance. Example 2 is difficulty staying asleep and may wake throughout the night and tends to wake up before their alarm. This is because their cortisol spikes early in the morning as they are anxious about their day. Now, it's normal to have this pattern on the day before a big presentation or before an early morning flight. However, it's not good for HPA access when every single day is like this. Example 3 feels anxious during their day. Maybe they have a stressful work environment that's keeping their cortisol elevated in the afternoon and evening when they should be winding down. And when cortisol is elevated midday, these patients tend to have problems with blood sugar control, as cortisol increases blood sugar even when they haven't eaten. Example 4 is our first patient in stage 3. They have difficulty waking and feel tired or groggy for the first several hours of the day. They aren't able to get going until they've had at least 2 cups of coffee. This is because their morning cortisol is quite low. Example 5 is late stage 3. These patients feel tired throughout the day. They tend to have problems with low blood pressure and also crave salty foods. They may have issues with blood sugar control, but it tends to be on the hypoglycemia side instead of the hyperglycemia side. When patients get to stage 3, they benefit from regular meals and snacks, anything really to nourish their body and soothe their fried adrenal glands. All right, transitioning back to the report walkthrough. The next part of the summary shows the values for all 9 adrenal hormones and metabolites, including deoxycorticosterone and corticosterone. These are both precursors to aldosterone, which offers insight into the renin-angiotensin-aldosterone system, or RAS, pathway function, stress, response, and potential hypertension risks. And notice that all adrenal hormone markers are in range. After adrenal hormones come diurnal cortisol markers, giving you the actual values for each of the 5 dots seen on the graph. And notice here that nighttime free cortisol is above the reference range. Any type of marker is outside of the reference range on the summary. The summary will include an interpretive comment about that marker, along with supplement suggestions. In this example, the supplement suggestions include magnesium, vitamin C, ashwagandha, and tangerine, a polymethoxylated flavone found in citrus peels. If available, you'll also see supportive supplement suggestions here. These are supplements which enhance specific associated functions without directly influencing markers. Next is the diurnal cortisone markers. Notice that all 5 cortisone markers are in the green, so no comments populate on this report. The last category in this section is diurnal melatonin. Since 2 markers were out of range for melatonin, you get 2 interpretive comments, one for the first morning melatonin and another for the pooled melatonin. And notice that the more out of range markers, the longer this section becomes. The next section of the report is the super helpful sex hormone flowchart. So, starting in the upper left, we can turn pregnenolone into progesterone, which can become beta pregnenolone or alpha pregnenolone. And ideally, we want to favor alpha pregnenolone as the alpha version is shown to improve sleep and reduce anxiety. We can also turn pregnenolone into DHEA, and DHEA can be made into other androgens like GHAS, androsterone, and testosterone. This section also provides information on 5-alpha dominance. 5-alpha reductase is an enzyme that takes testosterone and converts it into the much more potent DHT, which cannot aromatize into estrogen. Notice the dotted lines from androstenedione to estrone, E1, and from testosterone to estradiol, E2. When DHT levels are elevated, this can lead to symptoms like cystic acne, especially along the jaw or chin, hirsutism, female pattern baldness, mood swings such as anger or irritation, and PCOS symptoms. We can also turn androgens into estrogens, mainly through the aromatase enzyme. The estrogen section provides additional insights on liver detoxification, specifically by quantifying how much 16-OHE1, 4-OHE1, and 2-OHE1 your patient is making via the cytochrome 3A4, cytochrome 1B1, and cytochrome 1A1 enzymes, respectively. These ratios are reported in the upper right-hand corner of the estrogen section. In this example, the patient is only making 49% 2-hydroxy, but ideally should be between 55 and 75%. Meanwhile, they're making 37% 4-hydroxy, which should be much lower at 8 to 16%. Good news is their level of 16-OH is within the expected range of 14 to 33%. Now I'll explain why we aim for these ratios. The cytochrome A1A pathway creates 2-hydroxy-E1 and methylated products. And the reason we want to dominate this pathway with 55 to 75% of estrogen metabolites is because the 2-hydroxy metabolites are anti-carcinogenic and have an inhibitory effect on cell proliferation. The 2-hydroxy metabolites are also methylated at a faster rate than the 4-hydroxy metabolites, thus are stabilized quickly and are much more stable on their own. More stable means less oxidative stress within the body. In contrast, the cytochrome 1B1 pathway creates the 4-hydroxy metabolites, which can turn into quinones. If not detoxified, the 4-hydroxy-E1 can bind to and damage DNA. We want to minimize this pathway, and the goal is 8 to 16%. It can't be 0, but we want to minimize or at least help support getting off this pathway whenever patient levels are elevated. The cytochrome 3A4 pathway is considered proliferative. So we do want to encourage 16-OHE1 if you're looking to support bone health, but not so much if your patients suffer from proliferative conditions like heavy periods, clot fibroids, breast tenderness, and breast fullness. One of my favorite parts of the report is the speed dial showing methylation activity. This dial shows how well your patient's turning 2-hydroxy-E1 into 2-methoxy-E1. But the insight doesn't end there. When we zoom out and look at all 13 estrogen markers, you can see that Vibrant's Hormone Zoomer includes a total of four, not just one or two or three, but four methoxy metabolites. When you compare methoxy metabolites to hydroxy metabolites, this provides insight on methylation status, since you'll have fewer methoxy metabolites when methylation isn't working optimally. On a related note, it also provides insight on phase 1 versus phase 2 estrogen metabolism in the liver because hydrolysis is a phase 1 functionalization reaction and methylation is a phase 2 conjugation reaction. This is an important concept, so let's explore methylation activity in more detail. Hydroxy metabolites are on the left and methoxy metabolites are on the right. 2-hydroxy-E2 gets turned into 2-methoxy-E2. 2-hydroxy-E1 gets turned into 2-methoxy-E1. 4-hydroxy-E2 gets turned into 4-methoxy-E2, and 4-hydroxy-E1 gets turned into 4-methoxy-E1. One vibrant advantage is that the hormone zoomer includes three, not just one or two, but three methoxy to hydroxy ratios, providing comprehensive insight on methylation activity. We know that when methylation is good, we can assume B12 and folate sufficiency. But keep in mind that the methylation dial on the previous page only looks at conversion of 2-hydroxy-E1 into 2-methoxy-E1 down that cytochrome 1A1 pathway. However, that's not the only pathway impacted by methylation. Sometimes methylation isn't happening down the 1B1 pathway, which we can see from the other two ratios. Here's another way of looking at it. While methylation of 2-hydroxy-E1 into 2-methoxy-E1 is in the green, methylation of 4-hydroxy-E1 into 4-methoxy-E1 is in the red, which means methylation detoxification of 4-hydroxy-E1 and E2 is slow. Therefore, most of the 4-hydroxy metabolites are getting made into reactive quinones and likely causing DNA damage. Another way to confirm DNA damage is by looking at the oxidative stress marker 8-OHDG. Briefly, of the four nucleotides used to make our DNA, guanine is the most prone to oxidation. When oxidized, guanine in DNA becomes 8-hydroxy-deoxyguanosine, or 8-OHDG for short. You can think of this as rusty DNA. When your DNA damage repair enzymes find 8-OHDG, the repair enzymes replace the 8-OHDG with the regular guanine, and the 8-OHDG is excreted in the urine where we can measure it. This person's results show high levels of 8-OHDG at 10.76, indicating that this patient has elevated oxidative stress. After estrogens comes the 5 progesterone metabolites. Progesterone is the feel-good hormone, so lower progesterone in women can lead to symptoms like anxiety, poor sleep, and irritability, as it supports calming neurotransmitters like GABA. Additionally, low progesterone compared to estrogen can also cause symptoms of estrogen excess like breast tenderness, heavy cycles, and contribute to growth conditions like fibroids and endometriosis, even if estrogen levels are within the normal range. In other words, it's not always high estrogen, but the lack of opposing progesterone that's causing the symptoms. After progesterone comes the 7 androgens, including testosterone and metabolites. Testosterone is often considered the Goldilocks hormone because it needs to be just right, not too high and not too low for optimal health. Too little testosterone can lead to fatigue, low libido, depression, or mood changes, also reduce muscle mass and strength, decrease bone density, and also cognitive issues. On the other hand, too much testosterone, whether endogenous or from supplementation, can result in irritability and aggression, acne or oily skin, hair loss, elevated red blood cell count, increased cardiovascular risk, and hormonal imbalances, including estrogen dominance from aromatization. The last part of the hormone section includes the 10 hormone ratios. In addition to 3-methylation activity ratios, another ratio worth pointing out is the testosterone to epitestosterone ratio, which can provide insight on both anabolic steroid use and the UGT2B17 deletion. The takeaway here is that epitestosterone does not convert into testosterone. Therefore, testosterone therapy or anabolic substances do not increase FET, but will increase testosterone. Anti-doping agencies suspect doping when the T to epi-T ratio is greater than 4:1. As for the UGT2B17, this gene deletion impacts glucuronidation of androgens. While testosterone is primarily glucuronidated by UGT2B17, epitestosterone is glucuronidated by UGT2B7. Therefore, if you have the UGT2B17 deletion, your urinary testosterone will appear very, very low compared to epi-T, but this is actually a false low. So if your patient has that UGT2B17 deletion, you'd want to use serum androgen testing to get an accurate testosterone measurement. Another thing worth mentioning is the results are reported as both a number and plotted graphically, so you can visually see how high or low your patient's results are. In addition to adrenal and sex hormones and metabolites, the Hormone Zoomer also screens for 13 endocrine disrupting chemicals like BPA, phthalates, and parabens. This is the first time you'll see the yellow category on the report. While urinary hormones are either in range or out of range, endocrine disruptors are based on percentile. Results in the green correspond to the 0 to 75th percentile and indicate mild exposure. Results in the yellow correspond to the 75th to 95th percentile, indicating moderate exposure. And results in the red correspond to the greater than 95th percentile, indicating exposure is higher than 95% of the population. For each chemical that is elevated, the report will include a comment explaining common sources and the symptoms of toxicity. It will also identify all the hormones affected and explain the mechanism or mechanisms of action. For example, parabens bind to estrogen receptors, imitating estrogen's function and also amplifying its effects. Parabens also block the enzyme 17-beta hydroxysteroid dehydrogenase, which regulates the conversion between estradiol and estrone, disrupting hormonal balance. The summary also includes supplement suggestions and/or supportive supplement suggestions. So endocrine disruptors can be agonists, mimicking hormone function. For example, glyphosate may affect androgen signaling by interacting with androgen receptors, thereby mimicking the effects of testosterone. Endocrine disruptors can also be antagonists, blocking hormone function. They can modify receptor expression, affect hormone distribution and levels in circulation. Endocrine disruptors can also block hormone signaling directly or impact hormone transport, affect hormone clearance, interfere with epigenetic modifications of hormone-producing cells, or impact hormone synthesis. For example, atrazine has been shown to boost estrogen production in animals, which is linked to lower testosterone levels and higher estrogen levels in the blood. Atrazine increases the activity of aromatase, the enzyme responsible for converting testosterone to estrogen. Finally, endocrine disruptors can alter hormone-producing cells. As an example, triclosan exposure increases a process called decidulization, where uterine cells prepare for placenta formation, potentially disrupting normal reproductive functions. Thinking about all these mechanisms of endocrine disruption really highlights the value and importance of doing a toxin screen in conjunction with hormone replacement therapy. For example, if a female patient's response to estrogen therapy seems inconsistent with the prescribed dose, perhaps she's experiencing stronger effects than anticipated, endocrine disruptors like bisphenol A may be playing a role. BPA is a xenoestrogen, meaning it mimics estrogen and can bind to both estrogen and androgen receptors, disrupting normal hormone signaling. Research using cell lines in animal models has shown that BPA can increase levels as steroid receptor coactivator 1, a protein that enhances hormone receptor binding and gene activation through hormone response elements on the DNA. Similarly, if a male patient is receiving testosterone therapy but isn't responding as expected, BPA toxicity could also be a factor here. BPA has been shown to interfere with the androgen receptor function, reducing its ability to bind testosterone and dihydrotestosterone. This disruption may dampen the biological effects typically mediated by these hormones and contribute to a suboptimal clinical response. The hormone Zoomer also includes two bone health markers, deoxypyridinoline, or DPD, and pyridinoline, PYD, to assess for bone degradation. DPD provides structural stiffness to the collagen type 1 found in bones and stabilizes collagen by forming cross links between individual collagen peptides. PYD is a molecule that forms cross links between collagen fibers during the extracellular maturation of collagen. During bone resorption, cross linked collagen is broken down, releasing DPD and PYD cross links into circulation. Therefore, low levels of DPD and PYD are generally desirable as they indicate normal or minimal collagen breakdown and suggest balanced bone and connective tissue turnover. On the other hand, high levels of DPD and PYD indicate increased risk for bone loss and a higher risk of osteoporosis and fractures. Hormones such as estrogen and testosterone play a crucial role in maintaining bone health by regulating bone formation and resorption. An imbalance in these hormones, such as decreased estrogen levels during menopause, can result in increased bone loss. Therefore, monitoring bone health is critical for aging populations, perimenopausal women, and patients on hormone therapy. As with the other sections, the bone marker summary will include an interpretive comment and supplement suggestions for each marker that is out of range. For this result of elevated DPD, the report recommends 1,500 milligrams of calcium daily to support bone health. The summary ends with a summary of all the supplement suggestions, organized by category. This eliminates the need to upload results to a third party analyzer to get supplement suggestions, as all the suggestions are included on the report. On a related note, the lab uses a weighted ranking approach for supplement suggestions. This ranking considers both how often a supplement is recommended and its evidence based rating. This means higher rated supplements will appear at the top, ensuring those with a 5-star rating come first, followed by 4-star, 3-star, and so on. This weighted ranking system for supplement suggestions provides helpful evidence based suggestions for both healthcare providers and patients to make informed choices. Finally, the report ends with a list of all markers. All right, now that we've reviewed the Hormone Zoomer sample report, let's apply what we've covered in a case study. Meet Kathy. Kathy is a 40-year-old female who is 5'7" and weighs 150 pounds, making her BMI 23.5. She has a high-stress corporate job as a project manager, uses conventional beauty products, frequently drinks from plastic water bottles, and wears a plastic night guard every night. She gets poor sleep and eats a diet high in processed food. She complains of chronic fatigue, weight gain, irregular menstrual cycles, particularly spotting before her period, mood swings with irritability, insomnia, and joint pain. She has a history of infertility and reports increased stress levels and also worsening PMS symptoms. Her previous provider ordered a urinary hormones test, which showed elevated androgens, including DHEA and androsterone, above the reference range, and a high normal etiocalanolone with a 5 alpha preference and an above range 5 alpha DHT level. Meanwhile, she also had low estrogens, including low estrone, low estradiol, and low 2-hydroxy-E1, indicating that the cytochrome 1A1 pathway wasn't being utilized optimally. Since estrogen plays a crucial role in fertility, stimulating the growth of uterine lining and triggering a surge in luteinizing hormone, which leads to ovulation, her previous provider put her on a traditional Chinese combination of white peony and licorice to increase the conversion of her high androgens into more estrogen. White peony specifically is seen to increase aromatase activity, turning more testosterone into estradiol. She was also taking DIM, to induce the 1A1 pathway. And note that DIM also activates the 1B1 pathway, but to a much less extent than the 1A1 pathway. So I kept all this in mind when reviewing her Hormone Zoomer results. The first thing I noticed about Kathy's results was the elevated morning cortisol. It's no wonder she's waking up before her alarm. Her body is preparing for a fight before she even gets out of bed. The other thing I notice is that Kathy's cortisone curve does not mirror her cortisol curve. Cortisone is the inactive metabolite of cortisol and generally serves as a secondary confirmatory marker for assessing changes in free cortisol levels. However, since Kathy's first morning and second morning cortisone were low compared to her first and second morning cortisol, this tells me that Kathy's having a difficult time inactivating her cortisol. Thus, she's getting that stress response for longer than needed. This was confirmed by the total cortisol versus total cortisone level speed dials at the bottom of this page. Total cortisone is in the middle of the range, but total cortisol is quite elevated. You can get the same information by looking at the cortisol to cortisone speed dial, which includes a comment about how increased cortisol levels have been associated with conditions like metabolic syndrome and insulin resistance. On a related note here, licorice root limits the activation of free cortisol into cortisone, so caution is warranted in individuals with hypertension. The next thing I notice is Kathy no longer has androgen dominance. Instead, Kathy's androgen levels are all in the green. Just look at how low her testosterone to epitestosterone ratio is. And you can tell by looking at the speed dial that Kathy is no longer favoring 5 alpha dominance after taking that formula with licorice and white peony. However, I had to wonder if that formula with licorice was the best option for her, given her very elevated cortisol to cortisone ratio. Instead of elevated testosterone, Kathy is now making tons of estrogen, specifically estradiol. The estradiol speed dial is cranked all the way to the right. Also notice the impact DIM was having on her estrogen metabolite. The DIM really sped up Kathy's A1A pathway. Just look how high her 2-hydroxy E1 is. Focusing on the phase 1 estrogen metabolite ratios, she's currently making 77% of the 2-hydroxy, but only 8% of the 4-hydroxy and only 15% of the 16-hydroxy. Now, this would seem like a good thing, right? Well, it might be if Kathy was also methylating and removing all those activated intermediates through phase 2, but she isn't. Check out the methylation dial. Many of the activated 2-hydroxy E1 metabolites are accumulating and likely causing damage. Looking at the oxidative stress section confirmed that her 8-OHDG was actually quite elevated at 13.6, which is indeed a sign of DNA damage. Taking a look at the progesterone section, we see that all of Kathy's progesterone metabolites are within range. However, if you look at the beta-pregnenolone dial to E2 ratio in the hormone ratio section of the report, you can see that her progesterone is low compared to estrogen. When a patient has normal progesterone levels but a low beta-pregnenolone dial to E2 ratio, this suggests a relative progesterone insufficiency in the context of estrogen dominance, even if the absolute hormone values are within range. This imbalance in ratio can reflect insufficient progesterone activity to counterbalance estradiol, leading to estrogen dominant symptoms like irritability, mood swings, and breast tenderness, all of which Kathy complains of. Hormone Zoomer results also revealed that Kathy has several elevated endocrine disruptors, including BPA. BPA is commonly found in plastic bottles, sports equipment, CDs, DVDs, and the thermal paper used for sales receipts. Additionally, many food and beverage cans are lined with epoxy resins containing BPA, so it's really common to have elevated BPA. In addition to BPA blocking hormone signaling, as we talked about earlier, BPA also modifies receptor expression, causing alterations in the epigenetic processes that affect hormone action, blocks hormone transport, and affects hormone distribution and levels in circulation. Kathy also had elevated ethylparaben. Ethylparaben is used as an antiseptic in cosmetics, food, and medicine. It's readily absorbed through the gastrointestinal tract and through the skin, is then hydrolyzed to hydroxybenzoic acid. These molecules are endocrine disruptors, and ethylparaben mimics estrogenic activity, thereby increasing levels of estrogen in the body. Finally, Kathy also showed increased deoxypyridinoline DPD, indicating increased risk of bone collagen degradation and a higher risk for her to develop osteoporosis and fractures in the future. The supplement suggestions for Kathy's adrenal hormone results included 350 milligrams magnesium per day, 1,500 milligrams vitamin C per day, 600 milligrams ashwagandha per day, and 200 milligrams tangerine per day. Magnesium helps decrease cortisol by regulating the HPA axis, acting as a cofactor for enzymes involved in neurotransmitter synthesis, promoting GABA activity, and reducing excessive neuronal firing, which helps lower cortisol production. Additionally, magnesium enhances sleep quality, further reducing cortisol levels. Vitamin C supplementation decreases cortisol levels by reducing the secretion of cortisol in response to stress. It also supports the adrenal glands, improving their function and reducing excessive cortisol release. Additionally, vitamin C acts as an antioxidant, mitigating oxidative stress that can stimulate cortisol production. Ashwagandha decreases cortisol by inhibiting the HPA axis activity, leading to reduced cortisol production. Additionally, ashwagandha's bioactive compounds modulate neurotransmitter activity, further aiding in stress reduction. And tangerine decreases cortisol levels by inhibiting the enzyme that converts inactive cortisone to active cortisol. Additionally, tangerine's antioxidant properties may mitigate stress-induced cortisol secretion, further lowering cortisol levels in the body. The supplement suggestions for elevated estradiol and 2-hydroxyestrone include 600 IU's vitamin D per day and 10 grams wheat bran per day. Vitamin D supplementation can lower estradiol levels by promoting the expression of enzymes that convert estradiol to its less active metabolite. Consequently, increased vitamin D levels can also result in reduced estradiol concentrations in the body. Wheat bran increases dietary fiber intake, which binds estrogens and enhances their excretion through the feces. This process reduces the enterohepatic recirculation of estrogens, leading to lower serum estrogen levels. The androgens and progesterone metabolites were all within range, so no supplement suggestions populated for those categories. However, the hormone ratio supplements included a second suggestion to have the 600 IU's of vitamin D per day, as vitamin D supplements decrease the cortisol to cortisone levels by modulating the HPA axis, leading to reduced adrenal gland secretion of these hormones. Additionally, vitamin D's anti inflammatory properties can indirectly lower cortisol levels by reducing systemic inflammation. They also recommended the active form of vitamin B6 for its anti cancer effect and fenugreek seed extract because it increases testosterone. Supplement suggestions for the elevated endocrine disruptor BPA included a diet rich in soy isoflavones, which can reduce BPA's endocrine disrupting effects by competing with BPA for binding sites on estrogen receptors, mitigating its toxic impact on hormonal balance. And also a handful of supplements with antioxidant properties that scavenge reactive oxygen species and reduce the oxidative stress caused by BPA, including green tea, resveratrol, ginseng, luteolin, and astragalus. There are no supplement suggestions for ethyl paraben, but Catherine's report highlighted vitamin E, vitamin C, and iodine as supportive supplement suggestions. As a reminder, these are supplements that enhance specific associated functions without influencing the markers directly. So, taking all that information into account, here's the plan I put together for Kathy. First, we discuss stress management. I explain the impact of stress on hormones and share the Institute for Functional Medicine's strategies for transforming stress handout. They acknowledged that mornings tend to be stressful for her and decided to try spending a few minutes writing in a gratitude journal while drinking her coffee in the morning. That led to a conversation about the timing of coffee versus breakfast, and she was able to connect the dots and see that caffeine intake before breakfast was causing her to feel more stressed. She also says she enjoys green tea, especially matcha lattes, so wanted to try drinking green tea with the gratitude journal and drinking her coffee with breakfast instead of before. I educated her on adequate calcium intake to support bone health and gave her the IFM's food sources of calcium handout and explained that calcium is best absorbed in divided doses. She was thrilled the matcha latte counted as one serving of calcium, and I encouraged her to focus on getting another calcium rich food at lunch and dinner. And then if she struggled to do this, we could consider calcium supplementation at night. I also educated her on the 3 phases of detoxification. She told me that she is sometimes constipated, so we talked about getting adequate fibers through whole foods, hydration, and exercise to promote regular bowel movement and regular urination. I also educated her on sources of BPA and ethylparaben and referred her to the Environmental Working Group's Skin Deep database to find alternate body care products. Kathy said she'd start using glass or metal water bottles instead of drinking from plastic and to avoid touching receipts. I also encouraged her to talk to her dentist about her mouth guard, as sometimes BPA exposure can come from the plastic there. As for supplements, I had her stop the licorice and white peony formula since that was pushing too much testosterone into estradiol and keeping her cortisol around for too long. I also had her discontinue the DIM. Instead, I had her start taking resveratrol. As the report comments affirm, resveratrol helps counter the oxidative stress impact of BPA exposure, and it has also been shown to lower testosterone and DHEA, to lower insulin and improve insulin resistance, so can be beneficial for patients with PCOS. It inhibits the cytochrome 1B1 pathway and also induces NRF2, which boosts production of phase 2 detox enzymes and endogenous antioxidants, helping the liver safely process and remove harmful substances. When discussing phase 2 methylation, she told me she had the high risk MTHFR SNP, so I also recommended a methylation support product that provides vitamins in their most bioavailable forms, i.e., methyl tetrahydrofolate and methylcobalamin, along with trimethylglycine to support methylation, adrenal stress, as well as healthy detoxification efforts in the liver. And for stress support, I recommended ashwagandha, vitamin B6, vitamin D, and magnesium before bed. As for follow up and monitoring, I referred her to counseling for additional stress management support. I also recommended repeating the Hormone Zoomer to ensure appropriate phase 1 and phase 2 response to the supplements and lifestyle changes. When it comes to hormones, you really want to test often to make sure your therapies are really having the impact you want. And then I also recommended she consider Vibrant's gut Zoomer test to assess for gut microbiome and estrobolome influences on hormone levels. For example, your patient may be making appropriate amounts of estrogen, but if they have an overgrowth of beta glucuronidase producing bacteria, they aren't able to remove those estrogens from the body, resulting in symptoms of estrogen excess. This is an important concept, so let's walk through the impact of beta glucuronidase producing bacteria in more detail using this graphic. Starting in the upper left, we know that the liver conjugates, i.e., combines estrogen with glucuronic acid so it can be removed from the body. Looking at the conjugated form in this diagram, the teal half circle is estradiol and the yellow circle is glucuronic acid. Ideally, estradiol glucuronide is sent to the gut to be eliminated in the stool. See the intestinal excretion listed at the bottom. However, gut microbes like Ruminococcus and Clostridium produce beta glucuronidase, which is an enzyme that reverses glucuronidation, returning estrogen to its deconjugated form, basically separating estrogen from the glucuronic acid binding protein, thus increasing the likelihood that estradiol is reabsorbed from the gut into the hepatic portal vein and sent to the liver, where the liver then has to process it again. In these cases, the solution is not to mess with the hormones first, but to first reduce the bacterial overgrowth and support liver detoxification so that estrogen can finally be excreted from the body. I'd like to share more synergistic tests, but before I do, I want you to think about Dr. Sydney Baker's TAC rules. Rule number 1: if you're sitting on a TAC, it takes a lot of aspirin to make the pain go away. In other words, it's difficult to heal if you don't identify the root cause or causes of your symptoms. Rule number 2: if you're sitting on 2 TACs, removing one does not necessarily result in a 50% improvement in symptoms. In other words, sometimes there's more than one root cause contributing to your symptoms. So, in addition to combining Vibrant's Hormone Zoomer and Gut Zoomer, also consider the Total Tox Burden bundle to investigate and reduce total toxic burden, not just the endocrine disrupting chemicals. Also, the oxidative stress profile, which includes 16 total markers of oxidative stress, not just the most common 8-OHDG. And if your patient has hormonal or adrenal patterns consistent with hypo or hyperthyroidism, or if they have endocrine disruptors that impact thyroid levels, consider Vibrant's thyroid test to evaluate key thyroid hormones and autoimmune markers. Another smart pairing is the saliva hormones test, which assesses bioavailable hormones. This can be particularly helpful for patients utilizing topical hormone therapy or patients with suspected adrenal and/or HPA axis imbalances. On a related note, HPA axis dysregulation is associated with alterations in the serotonergic system. And the neurotransmitters test assesses the serotonergic pathway. So, if your patient's hormone Zoomer results indicate HPA axis dysregulation, also consider the neurotransmitters test. Vibrance micronutrient test is another good option as it measures essential vitamins and minerals that play a role in hormonal health. Deficiencies can contribute to hormonal imbalances, and this test helps tailor nutritional intervention. Finally, if your patients have estrogen excess or deficiency, consider the NutriPro or Methylation panel, both of which reveal genetic polymorphisms which may lead to estrogen metabolism issues, such as mutations in the MTHFR or COMT gene. In summary, Vibrant Wellness uses gold standard methodology to measure your patient's adrenal and sex hormones and metabolites, endocrine disruptors, oxidative stress, and bone health markers, giving you insights on sex steroid hormone imbalances, adrenal APA axis imbalances, bone health, DNA damage, and exposure to endocrine disruptors, allowing you to identify the root cause of your patient's hormone related symptoms and craft personalized protocols to get your patients feeling better. And that's it. Thanks so much for watching. Please let me know if you have any questions. Right. I see there's a bunch of questions in the comments, so I'm going to scroll back to the top and we'll answer them in the order they were received. Okay, first question came in from Martha Lewis. What if a client urinates in the middle of the night? Great question. This happens all the time. You don't want them to collect the sample in the middle of the night because that's going to reflect cortisol from the middle of the night. Instead, you'll want them to collect actually when they wake up in the morning, the first morning urine, because that is when cortisol is going to be elevated and then ideally will continue to go up. So that 2 hours after waking, we'll see an increase in cortisol there. So definitely first morning, not middle of night. Great question. All right, next question. Dr. Luke says, I have a neurodegenerative patient who symptomatically can't go 48 hours without Lacuna. Is there a safe way to interpret results without skipping doses? Yeah, great question. So I believe this supplement increases testosterone. So you just want to interpret results knowing that that could have been elevated based on that supplement. Anytime you're doing a supplement or a medication or a hormone replacement, you just keep that in mind when interpreting the results to help you identify, is this elevated for a physiological issue in the body or because of a supplement or med you're giving? Next question from Natalie. Should both saliva and urine be collected the same day? Another great question here. So I think in a perfect world, you'd want to collect them on the same day because then you have the same physiological state to compare both the urine results and the saliva results. Um, Although comparing one versus the other across days, you should still have similarities. But for best result, trying to do them on the same day makes the most sense. Okay. Next question is, can you test a woman with a hormonal coil and what would be the method if so? So I believe we're talking about IUDs. If a client is on an IUD, likely they're not going to see very high progesterone on the results. You would test just like normal on days 19 through 21 of a 28-day cycle if that patient is still having a menstrual cycle. And if not, you just collect any day. If you don't know when they're at in their cycle because hormone levels are so suppressed, you don't know. Collect any time. Otherwise, if they are cycling, you'd still collect at the progesterone peak of the luteal phase. And absolutely, you can still test. You just get less information about the progesterone because most times that's decreased with the hormonal kind. All right, next question. Looks like Renee asked you test for the 5-alpha androgen dial elevations. Yes, it's on page 11 of our sample report. And I believe Chris can send that to you if he hasn't already. Oh, looks like he did. Fantastic. Excellent. All right, next question from Anne Marie. Do you have a list of pathogens or bacteria that increase beta glucuronidase? Great question. Vibrant makes it really easy for you because on the gut Zoomer, and Chris, if you could send the gut Zoomer sample report, It's on page 11. It actually lists beta glucuronidase producing bacteria. So it groups them all into one category. We use very specific primers for our PCR so we can identify exact microbes that are contributing, and we report it all, whether it's high or low. Um, Certainly, we can look up every single one of those if you need that. But it's listed as just one marker on the gut Zoom results as well to make it easier for you to interpret if your patient's levels are low or high. It's page 11 of the sample report, Anna Marie. Um, Next question from Louise. Are you retiring the prior urinary hormones test? Yes, we are. So the Hormone Zoomer replaces the urinary hormones test. So you are only able to order Hormone Zoomer moving forward. You can still order salivary hormones. You can combine both of those, but urinary hormones as a standalone test has been retired. So the question is, should patients hold hormone dosing, for example, testosterone treatments like creams and injectables? This is all addressed on our collection instructions page. Also, I believe we'll also include it in the follow-up email as well. Another question about collection. This is a urine test. The Hormone Zoomer is urine only, and we have a handout on when to use serum versus saliva versus urine for hormone testing. And you could absolutely do more than one collection method. Does Vibrant provide interpretation of reports to providers? Yes. So Vibrant does offer renowned clinical consultations. So if you would like to interpret your hormones and results, you can schedule a consultation with one of our clinical team members. We're also working on a Hormone Zoomer interpretive guide, which should come out soon. And the report also includes report comments. If you choose the summary version when you download your report, it'll include comments for everything that is out of range. And we also have an all out of range report that has comments for every single marker if you'd like to learn more that way before the interpretive guide comes out. So lots of ways to get more information about all the markers on Vibrant's Hormone Zoomer. All right, I think those are all the questions I can answer over the webinar. If you have additional questions, you can email hello@vibrant-wellness.com and we'll get them answered that way. Thank you so much for attending and hope you have a vibrant day. Take care, everyone.